Hello, I'm Dr. Erika Hamilton. I lead the breast cancer research program at Sarah Cannon Research Institute in Nashville, Tennessee. Happy to discuss today future directions in the management of ER-positive breast cancer. And this really is a complicated topic right now. Definitely have some riches with multiple targeted agents, novel endocrine backbones, and we're going to go through some of the story today. So first, let's go into the class that we probably heard the most about, the oral SERDs, or selective estrogen receptor degraders. So instead of aromatase inhibitors, where we think about blocking production of estrogen in postmenopausal women, the degraders really bind to that estrogen receptor. And as I like to tell my patients, chew it up and spit it out. So it can be particularly good for patients that have ESR1 mutations, but also have wild type estrogen receptor activity as well. The advantages of the oral SERDs is the fact that they're oral compared to fulvestrant, which is administered intramuscularly in this class and has some poor PK properties that make it a little bit tougher with less activity. Certainly, these have higher potency, and they've shown to be effective in patients that have already seen CDK4/6 inhibitors, which really is a standard in the first-line setting now. I love this slide. This was initially presented at San Antonio Breast Cancer Symposium by Dr. McDonnell from Duke, but really just showing you that despite the fact that we have maybe 10 or so of these compounds, they're really not all the same. And so you can see that across these estrogen blockers, all the way on the right, we have ones that have more prominent SERM activity, so selective estrogen receptor modulator. It can be pro-estrogen in some places and anti-estrogen in other. And then if we go all the way to the left side, you see more prominent SERD activity. So ARV-471, the Protac, fulvestrant, very much SERDs. Over on the right, we see drugs that we're familiar with, like tamoxifen, that's a SERD. But you also see that elacestrant is actually a little bit towards the right side of the screen. Most of our oral SERDs are in this third category in the box that you see a little bit to the left of middle. And so I think it's important to remember that despite the fact that all these compounds may be SERDs that we're talking about, they do have some differences in their structure, which really can affect function. And so there may be certain situations where one drug is better for a patient than another. So if we look at some of the oral SERDs in development, we have elacestrant, which is our current FDA-approved oral SERD for patients that have ESR1 mutations. We have camizestrant in the second column, which is the other oral SERD that's had positive data in a randomized trial, both at 75 milligrams as well as 150 milligrams is moving forward in development. And then we also have giredestrant as well as imlunestrant over on the right. You see GI toxicity to be really common across most of this. I find this to be quite mild, very easy to manage. The majority of my patients are not on any antiemetics, and anyone that does have a little bit of nausea, typically one antiemetic that they take at home is more than enough to control this. We can also see some diarrhea. This is also quite mild. It is not diarrhea like tyrosine kinase inhibitor diarrhea. And then we also have some with some unique side effect. Visual disturbances and bradycardia. We actually see the bradycardia with giredestrant at the higher doses as well. These really tend to not be very bothersome for patients. The bradycardia is just a lower resting heart rate. If we walk a patient around the nursing station, their heart rate comes up. So I really describe this to patients as if you typically have a resting heart rate in the 80s, it's going to be 70. If you have a resting heart rate in the 70s, it's going to be 60. The visual disturbances are quite interesting, and I think at first glance, this seems alarming to people, but this is not blurry vision. This is not patients not being able to see, drive, anything like that. What this is it's actually a change of light phenomenon. So I like to call it the movie theater effect, where when you come out of the movie theater, you might have waffling at the edge of your vision for a little bit until your eyes adjust to the light. And what these patients notice is when they turn off their nightstand at night, they have waffling at the edges of their vision for a couple of minutes, or when they walk into the bathroom in the first thing in the morning and they flip on the light switch. And this is actually just due to the changes in light. Is temporary, goes away when we stop drug, and really doesn't affect any function.
This is the first time I heard about this visual thing. It sounds a little bit like crizotinib Are you familiar with what they see with crizotinib as targeted therapy in lung cancer?
I am. We think we now understand actually why this happens. The bradycardia and the visual disturbances are actually related. It's actually an ion channel and it's present in the rods in the eye as well as in the heart. So it's just a temporary side effect when patients are on drug. So I think, much more reassuring than, say, eye toxicity than we see from antibody drug conjugates or something like
Right,
that, which really
right,
can be problematic for
right.
patients.
But in terms of the patient experience, is it like the crizotinib thing?
I don't know. I haven't treated a lot of patients with crizotinib by any
Because they
stretch.
talk about
Only really
colors too. I've even heard
no
people say
colors.
it's a little bit, yeah. So I don't think it's exactly the same. As long as I brought that up, there's one other thing I just want to bring up to you. Maybe you're going to get into it later, but I just want to bring it up because when I saw that graphic with the SERD and all, I hadn't seen that either. It is really cool. But let me ask you something. To what extent is ESR1 a predictor of treatment benefit? And is ESR1 a predictor of treatment benefit of fulvestrant?
Yeah, that's a fantastic question about the ESR1. I feel pretty strongly on this issue, and I think there's plenty of people that will disagree with me. This is a pretty hot topic right now. The reality is that across drugs, whether we talk about a CIRCA, a PROTAC, or a SERD, we see patients that have ESR1 mutations tend to do better on their next line of endocrine therapy. I really don't think that it's really the drug that works that much better when there's an ESR1 mutation around. I think what this is predicting is just patients that remain endocrine sensitive. So post CDK4/6, we have a good percentage of patients that just aren't sensitive to endocrine therapy anymore. And you can see this in the Emerald curve, where about 40% of patients progress at the first scan, regardless of what arm they're on. And so I really see ESR1 mutations as a way to enrich the population for patients that are still endocrine sensitive and are going to get benefit out of endocrine therapy. Because the reality is if we're treating in a randomized trial, standard endocrine therapy with a SERD, and people just aren't endocrine sensitive, you're not going to see a difference for the oral SERD because they're not going to respond to either one, right? I have quite a few patients in my phase 1 unit that continue to be on oral SERDs. I would say upwards of about 30. And many of these patients are actually wild type. So again, I don't think it's anything truly special about ESR1. I think it's just a way, in the absence of a better predictor, to predict patients that are still endocrine sensitive.
I mean, do you agree that elacestrant should be only used in ESR1 positive patients then?
Yeah, I do. I understand why the approval was. The reality of the elacestrant data was that there was a benefit, across the board, but it was really very small magnitude. And it was 1 month. And if you pick patients that have ESR1 mutations, you were able to kind of, increase that benefit to 2 months. But really, that's not good enough. And I'm very curious to see the other oral SERDs data, because in the slide that I showed previously, elacestrant is the most SERM of our SERDs, right? And so when we get into some of these drugs that are kind of more pure SERDs, more pure degraders, I'm really hoping that they have better activity than elacestrant, to be honest.
Wow, that's really interesting. Please continue.
So we can see, I think it's very tough to do cross-trial comparisons, particularly in the second and third line patients with ER positive disease. We see a lot of heterogeneity, but you can see progression-free survival, SERD versus endocrine therapy on the bottom of this graph, post CDK4/6 inhibitor. And so you can see elacestrant 2.8 months versus 1.9. Camizestrant 7.2 versus 3.7. And you kind of ask yourself, well, why does that look so much better? Why is fulvestrant getting 3.7 months? Remember, in the camizestrant, not everyone had seen CDK4/6. It was a little bit more 50-50. And so that's why, in general, patients are doing better for longer. But we certainly see a pretty large benefit there with camizestrant. And then in the giredestrant in the metastatic setting, this trial was negative. And so this is still moving forward in other settings, but it is not right now in second line disease. So let's talk about the Serena-2 trial. This was recently presented. This was what I mentioned was the other oral SERD that we've had positive randomized data for. So these were patients that had had no more than one line of endocrine therapy in the advanced setting and no more than one chemo. So note here that they don't have to have had a CDK4/6 inhibitor, depending on the country. Some patients didn't have access, but quite a few patients did. And they were randomized in a 1:1:1 fashion, essentially, for camizestrant 75 milligrams, camizestrant 150 milligrams, or fulvestrant. Now, what we saw, you can see ESR1 mutations really kind of varied 30, upwards of about 45%. Prior CDK4/6 inhibitor was right at about half of the population, and the majority of patients did have visceral disease here. When we look at progression-free survival, you see the 2 doses of camizestrant in blue, the lighter color blue at 75 milligrams and the darker color blue at 150 milligrams. And both of these are clearly doing better than our red line fulvestrant. So really looking quite similar here at both doses. So you can also see over on the right, when we look at patients that have ESR1 mutations, progression-free survival, looking, 7, 9 months, et cetera. And those patients that were receiving fulvestrant is less than 4 months. So I think this is really encouraging data, and camizestrant is moving forward in multiple settings right now: adjuvant setting, first-line setting, first-line switch setting based on ctDNA and ESR1 mutations.
Maybe I missed it, but what was the ESR1 status in Serena-2?
In Serena-2, ESR1 mutations a little bit different per arm, but about 30 to upwards of about 45% of patients having ESR1. So pretty typical for what we would expect in the second-line setting.
So they have a phase 3 now?
Yes.
Same thing versus fulvestrant?
Yes, and then they also have Serena-6, which is a ctDNA monitoring protocol. So essentially take first-line patients that are on AI and CDK4/6, and if they pop positive for ESR1 at any point, then they're randomized either to stay on the endocrine therapy they're receiving in the absence of clinical progression, or they get randomized to go on to camizestrant with CDK. So kind of asking that question of, technology-wise, we can test for these ctDNA, but what do we do with it? And are we helping our patients with these early switch strategies? So I'm really excited to see the results of that trial.
Yeah, that is really cool.
They also have a trial in the adjuvant setting right now for patients that are a little bit higher risk. And, the part that I'm really excited about for the adjuvant setting for oral SERDs is, if we had to pick a problem for oral SERDs, it's the fact that second line and beyond, a lot of patients just have endocrine resistance. And so we shouldn't see that in the adjuvant setting. And similarly, for some patients that aren't getting CDK4/6 inhibitor, it's a little bit more of a pure test, endocrine therapy to endocrine therapy. So that trial's actively enrolling now as well.
Let me ask you, I've heard about these trials, adjuvant trials of SERDs, and is that because I think I've seen one where it was like patients who weren't tolerating an AI or something, but they have just straight adjuvant, that this is all you get is the SERD, nothing else. That seems interesting. Let's just say, with all the data we have,
I'm quite excited to offer that to patients. If you compare side effects, our adherence on adjuvant AI for 5 years is less than 50%. And really that's due to a lot of sexual side effects, arthralgias, et cetera. And the side effect profile of oral SERDs are a little bit different. We have a little bit of GI disturbance. Now, certainly it hasn't been particularly problematic in the metastatic setting, but whenever we put something in the adjuvant setting, patients' kind of willingness to tolerate symptoms certainly changes. So we'll see what we see there. But we haven't had any trials where an oral SERD has lost to standard endocrine therapy. We've had 2 that are clearly positive. We have one where it pretty much look the same or numerically better, but not statistically significant. So I've been offering this to many of my patients because I think that there's going to be some advantages there. If you recall, fulvestrant actually looked quite better than AI, but they'd run out of patent life at the time. And we know that fulvestrant, being our intramuscular SERD, really is a quite inferior compound compared to the oral SERDs.
I mean, I'm just going to say, though, with the history of adjuvant endocrine therapy and the powerful effect on, recurrence and survival that's so well documented. I mean, and these drugs, I mean, I don't think have they even been used in people who've not had endocrine therapy?
Who have not already had endocrine therapy?
Yeah.
Well, yeah, I mean,
Right.
there's been neoadjuvant trials, SERDs
Oh,
versus
really?
AI, better knockdown of Ki-67.
Really? Huh.
Yeah, I mean,
Oh, that's interesting.
it's definitely a good endocrine therapy.
Huh. Interesting. But I didn't know about the neoadjuvant. That's very interesting as well.
I mean, it's tough in ER positive disease neoadjuvant because you can't really design your trial as PCR rate, like triple negative, right? Because these tumors aren't
Yeah.
just going to completely melt away. But there's been very good Ki-67 knockdown
Yeah,
data,
totally. Yeah.
shrinkage of tumors, et cetera. So that's reassuring.
Interesting.
So again, this goes through some of the adverse events, and just a reminder again that we can see these visual disturbances as well as GI toxicity and a little bit of bradycardia. I actually feel like my patients have less hot flashes on oral SERDs compared to aromatase inhibitors. So this may be an advantage for some patients that can really struggle with hot flashes. Also, sexual side effects, vaginal dryness can be a big problem that can interfere with intercourse, et cetera. And so, very excited to see this move into the earlier setting here of whether we may be able to improve some of these side effects, particularly for a therapy that patients remain on for 5, 7, 8, even 10 years, can really be a big quality of life issue for them. So this is Serena 4. So this is camizestrant with palbociclib, so our kind of straight up first line trial. And so this is randomized in a 1-to-1 fashion for patients that have not received any prior therapy for metastatic disease. And they had to have had at least 24 months of AI with a treatment-free interval of at least 12 months or 24 months of tamoxifen, or de novo metastatic disease is also allowed. I'm very excited that this trial does not only require measurable disease. They're also allowing patients that have a lytic or mixed lytic bone lesion, so a valuable disease as well. And as you imagine, this is either a kind of aromatase inhibitor palbo with a camizestrant placebo, or camizestrant palbo with an anastrozole AI placebo. So a very clean head-to-head trial in the first-line setting with CDK4/6. Ember 3 is very similar. This is a first and second line trial with oral SERD imlunestrant, which we've also seen quite a bit of data from. These patients, again, prior treatment with an aromatase inhibitor, they have locally advanced or metastatic disease, no other prior therapy for advanced disease. They can't have had prior targeted PI3, mTOR, AKT, et cetera. And they are randomized to imlunestrant or fulvestrant or exemestane, or this bonus arm looking at imlunestrant, abemaciclib. So kind of asking that question that the most patients in the second line setting here probably will have seen CDK, depending on the country. So asking that question of CDK after CDK. And so we're enrolling 800 patients for this trial. This is the trial that I mentioned before, and it's a little bit complicated here, but this is the Serena 6 trial. So it's the early switch strategy. And I like to explain this really as two different trials. On the left, all we're doing is we're just signing patients up to monitor ctDNA. Although there's many companies offering this right now, actionably, we're not sure what to do with it. Is somebody that has a ctDNA change, are we benefiting these patients by switching their therapy sooner, or are we just running out of therapies and not really ultimately improving their outcome? So on the left side of the screen here, you'll see this is just ESR1 mutation detection phase. And so every about 8 to 12 weeks, so, 2 to 3 cycles, they would come into the clinic to line up with scans, depending on how frequently you do your scans for these patients, and they would have a test for ESR1. If and only if They previously were ESR1 negative and pop positive for ESR1, saying, uh-oh, we're getting resistance. We've got active disease now. Then they go into the right side of the screen, which is the randomized treatment phase. And so for those patients would either continue on their AI with CDK4/6, or they would switch to camizestrant with CDK4/6. So asking that question of, is an early switch benefiting our patients ultimately? So beyond oral SERD, there's a host of other endocrine agents. I like to call this the endocrine word salad as we get into a lot of acronyms. So we have PROTACs. This is proteolysis targeting chimeras. The most well-known compound here is ARV-471. A lot of data have been out of this. So this PROTAC is really our rainbow molecule you see here in the diagram. And when it binds our protein of interest, which here is the green estrogen receptor, it causes a conformational change that recruits in E3 ligase. When E3 ligase binds this, it targets the estrogen receptor for ubiquination, which ultimately is a signal for the cell to come in and treat this as an invader, chomp it up, and spit it out. So you can see the proteasome really degrading the estrogen receptor over on the right side of the screen. So again, very similar to SERDs, we anticipate activity in both wild type as well as patients that have ESR1 mutations. And in the phase 1 dose escalation study, we actually saw no dose-limiting toxicities. This really was a very well-tolerated drug. And the clinical benefit rate was about 40% with a few confirmed partial responses. So this is the phase 2 VERITAC, which is really an expansion at 2 different doses of ARV-471, getting at the FDA's recommendations to really make sure that you have the right dose nailed down, particularly for drugs like this where we may not hit an MTD. And so these patients have had at least one prior endocrine line. They've all had CDK4/6, and they've had up to 1 chemotherapy. So you can see that how this breaks down is everyone seeing CDK, about a third of patients having fulvestrant, close to half having chemotherapy, and a little bit more than half having an ESR1 mutation. What we see in terms of clinical benefit rate is really right at that 40% range, and similar to other drugs that we've talked about. If you pick patients that have an ESR1 mutation, you can boost this. So it boosts up to about 51% clinical benefit rate if we pick patients that have an ESR1 mutation. You can see at the 200 milligram dose, progression-free survival really looking to be a little shy of 4 months in all patients. And again, if we select patients that have ESR1 mutations, we can boost this up to about 5.5 months.
Do you see actual objective responses?
We had 3 partial responses that we did see. But again, with ER-positive disease and endocrine therapies, we typically don't see a lot of actual responses. We see cancer just kind of stall and stop. To really have substantial tumor shrinkage with endocrine agents is a little bit more rare. So I really like to measure benefit here by PFS. So if we're getting PFS in the 5-6 month range or longer, I'm thinking that that's a patient that's really benefiting. Recall in our 2 trials with fulvestrant that the progression-free survival post-CDK4/6 is less than 2 months, 1.8 months. And so if we're getting into that 5 and 6 month range, I think that these are patients that are really benefiting. And remember that for our patients that have progressed on CDK4/6, that once they've exhausted their endocrine therapies, they're moving to chemotherapy. And so really to be able to extend patients staying on endocrine therapy longer is the goal here.
But just to clarify, when you say it's unusual to see objective responses to endocrine therapy, do you mean people with previous disease or just in general?
Well, a little bit in general. Certainly, the later line metastatic disease, but remember that, in ER-positive disease, even with neoadjuvant chemo, our PCR rates are far less for patients that have ER-positive disease than triple negative. And that's really because it's not a very quickly dividing tumor. And so, chemotherapy just tends to not work as well. So same with endocrine therapies. We really see kind of stable disease or PFS typically CDK4/6 inhibitors have changed that a little bit. We do tend to see responses now in the first line setting with CDK, but historically, fulvestrant, et cetera, overall response rate really hasn't been our outcome in those trials. It's been PFS.
Interesting. I don't know if I ever told you that our company, Research to Practice, was launched on a video I did while I was at the University of Miami called Hormonal Therapy for the 1980s.
I love that.
We had this little Pac-Man thing of the estrogen receptor.
We didn't have so many drugs in the 1980s. It's changed just a little bit.
But, actually only fairly recently when you think about it. Like the
Absolutely.
last 3 or 4 years. Up until the last 3 or 4 years, I mean, there wasn't that much to talk. I mean, CDK mainly, I guess.
Yeah, I mean, in ER-positive breast cancer, we haven't had a new endocrine backbone since fulvestrant, right? I mean, it's all been targeted agents, CDK, mTOR, PI3, but not backbones. You're absolutely right.
Even though it's the most common subset.
Absolutely. So based on this data, really looking at 200 milligrams versus 500 milligrams, 200 milligrams was selected as the phase 3 dose. And just to note that this is a once daily drug, so a little bit friendlier to patients as well. So VERITAC-2, the phase 3 trial of ARV-471 versus fulvestrant in patients that have already seen CDK4/6 inhibitors is ongoing. So I'm going to switch gears to a different word salad endocrine backbone. This is a CERAN, so a complete estrogen receptor antagonist. And what I mean by complete here is shown in the diagrams. So both AF1 and AF2 really can drive transcription and ultimate signaling and proliferation and cancer growth. And signaling pathways typically really only affect one of these. They don't block both AF1 and AF2. And so complete antagonists directly turn off AF2, but also recruit an NCOR and turn off AF1 as well. And so that's what we mean by complete. Is shutting down both activation functions of the estrogen receptor. And this is OP-1250. And also is anticipated to have activity again, wild type and ESR1, and they're also interested in brain mets as well. So from the phase 1 trial, they looked at doses from 30 all the way up to 300 milligrams. These patients were really quite heavily pretreated, about 50% having more than 3 prior lines of therapy, 2/3 seeing fulvestrant, 3/4 of patients already having chemo, and almost everyone above 90% having prior CDK. What we saw, again, low overall response rates, but a clinical benefit rate here approaching 40%. Again, no DLT reached. That's why some of these neoadjuvant as well as correlative biopsies have been really important to make sure that we're getting the dose right. And we're also looking now on the right side of the screen, combination with CDK4/6 inhibitor. So OP-1250 with palbociclib. Very similar demographics. Stable disease, is quite common to see here. Longest duration of treatment was 31 weeks and ongoing. We certainly do see more neutropenia when we're combining with a CDK4/6 inhibitor, which is anticipated. So the recommended phase dose was ultimately determined to be 120 milligrams of OP-1250. So I really present all of those to show that there are new endocrine backbones coming. How they sort out of whether we use them sequentially, whether there's a certain patient population based on mutation phenotype or one's better than another, certainly remains to be determined. But I anticipate we'll see this not only in second line disease and beyond, but I think we're going to have novel endocrine agents in the adjuvant setting and in the first line setting, if I had to predict. So let's move to AKT inhibition. This is not a pathway we're unfamiliar with. We've had mTOR inhibitor with everolimus for quite some time. We now have had alpelisib for several years. And this is capivasertib, which is a pan-AKT inhibitor. We also had another drug, apatasertib, that we've also seen some results from and really highlighted here on the screen. In phase 1 trials, fulvestrant with capivasertib showed us an overall response range ranging somewhere from 20 to 40% and a progression-free survival of about 5.5 months. And this led to the phase 2 FACTION trial, where fulvestrant and capivasertib led to an improvement in progression-free survival, irrespective of whether somebody had an alteration in this pathway. So I mentally file the AKT inhibitors in the mTOR bucket, whereas PI3 inhibitors, we have to have a PI3 mutation. For mTOR inhibitors, you don't, and for for AKT, you don't as well. So this is Capitello 291. This was presented at San Antonio Breast in December of 2022 by Dr. Turner. And this is the phase 3 trial with the AKT inhibitor fulvestrant alone or fulvestrant with capivasertib. So who were these patients? They had 2 lines of prior endocrine therapy or less, 1 line of chemotherapy or less. Prior CDKs were allowed but not required, and they had to have had recurrence within 12 months of AI or progression while on an AI for advanced breast cancer. So kind of a so-called second-line setting trial. If we look in the bottom right, we see that AKT pathway alterations was about 40%. Prior CDK4/6 was really in about 2/3 of patients, and chemo was pretty rare, less than 20%. And this is what we saw. We saw progression-free survival of fulvestrant alone at 3.6 months. And when we added capivasertib, it was 7.2 months. Remember that these were dual primary endpoints. And so we also looked at progression-free survival for those patients that had an AKT pathway alteration. And it looked pretty similar. Fulvestrant doing a little bit worse at 3.1 months, but progression-free survival for fulvestrant and capivasertib is still 7.3 months. So really the benefit here looks to be irrespective of AKT pathway alterations. If we look at subgroups, whether patients had received prior chemotherapy, whether they have liver mets, whether they had prior CDK or not, we did not see really any differential activity here. And certainly the OS data is still quite immature. So the $1 million question is how is the tolerability? Because we certainly can get into problems with tolerability with PI3 agents as well as mTOR, although I feel like we've gotten a little bit better with that with the SWISH study and oral dexamethasone rinses. So you see that rash is a little bit less common than PI3. So about 20% of patients have some rash, only 5% having a grade 3 rash. Nausea, any grade occurring in about 1/3 of patients. So that's really not bad. That compares quite favorably with PI3 as well. Where we do see quite a bit of side effects is in terms of diarrhea. 3/4 of our patients have diarrhea. And you can see kind of this differential shading for grade 2 and then definitely more severe at grade 3. So I think there's some advantages. One thing that you'll notice that is not highlighted on the top of the screen is hyperglycemia. And so hyperglycemia is about halfway down and is really much less frequent with the AKT as PI3. So I think certainly in the United States, where we have a high percentage of patients that may struggle with blood sugars or be overweight, this is a clear advantage of the AKT inhibitors with having less hyperglycemia. So let's move on to the novel antibody drug conjugates. And I kind of ordered this for a specific reason. I think there's so much excitement around antibody drug conjugates and certainly warranted, but we need to think about antibody drug conjugates as a substitute for chemo. And so these are not drugs that we would give first-line ER-positive disease. We really want our patients to exhaust endocrine therapies when we would be thinking about chemotherapy. That's really where we're thinking about the antibody drug conjugates. So this was some data that I presented at ASCO, so conflict of interest here. This is patritumab deruxtecan, HER3-DXd. And so compared to our 2 approved antibody drug conjugates, sacituzumab govitecan, which is a TROP2 antibody drug conjugate, and trastuzumab deruxtecan, which is a HER2 antibody drug conjugate, this molecule is very similar to trastuzumab deruxtecan. So it has the same backbone, the same payload, same linker, but now it's a HER3 antibody instead of a HER2 antibody. So you can see that same DAR of 8, tumor selective cleavable linker, bystander effect, and it's an exatecan derivative payload. Now, this data was presented by Ian Kropp at ASCO last year, 2022. And you can see across all 3 types of breast cancer, HR positive, triple negative, or in the blue, HER2 positive, there's activity. And these patients are really heavily pretreated, median number of priors ranging from 2 to 6, depending on subtypes. And over to the right, you can see the duration of responses, 6 months all the way up to 8 months for triple negative. Responses really in this 3rd to 7th line population looking pretty encouraging, about a quarter of patients up to a little over 40%. We do see ILD. I think that's always our question when we look at antibody drug conjugates. It was about 6%, so less than we see with trastuzumab deruxtecan that really comes in at about 13 to 15% any grade ILD. These were all really grade 1, grade 2. There were only one grade 5 event. So yes, we see ILD, but it appears to be less frequent. This was presented at ESMO Breast this year in 2023 in May. This is Icarus Breast 01. This is metastatic breast cancer that's hormone receptor positive and either HER2 negative or HER2 low. And all of these patients had seen CDK and endocrine therapy. They had all already had a line of chemotherapy. So taxane, capecitabine, whatever that may be, and they all went on to receive patritumab deruxtecan at 5.6 milligrams per kilogram. 28% partial response rate, stable disease, another about half of patients. So certainly very reassuring data here. And then this led to phase 2 trial of HER3-DXd and HER2 negative. This was really kind of going on pretty simultaneous. We enrolled 2 different populations into this trial. Patients that would typically be called triple negative and patients that would typically be classified as hormone receptor positive. So everything other than HER2 here. And again, everyone goes on to receive patritumab deruxtecan. I want to call your attention to the box over on the right and the bottom where baseline HER3 expression, because that's the question with these ADCs. Is it like HER2 where we need to measure expression? Is it like sacituzumab where we don't really care what the TROP2 is? And what we see is that HER3 is highly expressed across multiple breast cancer subtypes. So 2/3 of patients have greater than 75% expression. Another quarter have what we would call low expression of 25 to 74%, and only 4 patients of 60 had HER3 expression less than 25%. Now, when we look at response based on this, we see no differential response based on expression. So you can see that clinical benefit rate for high is about 40%. Low is actually 54%. And I caution you to interpret the less than 25 because there were only 4 patients, but it was 50%. So no sign that we really need to be monitoring HER3 to see who's eligible for this, or that our patients that have higher HER3 expression are going to do better. So very similar to trastuzumab deruxtecan, where very little expression of the antigen is probably more than enough to get the job done here. So the all-comer overall response rate was 35%, overall clinical benefit rate of stable disease of at least 6 months or more, in addition, is 43%, and the duration of response was at least 6 months in nearly half of the patients who responded. This is the waterfall as well as the spider plots, really showing you based on the HER3 expression. I think that this is a pretty impressive waterfall plot, just showing that even those patients that may not have been a responder, a lot of patients still had some tumor shrinkage. And over on the right, you can see in blue those patients that are hormone receptor positive with depth of responses, as well as those patients with triple negative breast cancer and depths of responses there. So takeaways from this, really in combination with the Icarus, is that HER3-DXd is active across multiple breast cancer subtypes, irrespective of level of HER3 expression. Fatigue and a little bit of GI toxicity were the most common adverse events, and our rates of ILD were very low, 2%. So this certainly is being taken forward into multiple spots. So what other new antibody drug conjugates are on the horizon? This has a similar target to sacituzumab govitecan. So this is TROP2, but this is datopotamab deruxtecan. So again, our common exatecan payload, same linker, but now instead of being HER2 or HER3 on the front of it, the antibody is TROP2. So this is tropion pan-tumor 01. You can see that lung, triple negative breast, hormone receptor positive, et cetera, were included. And if we look at those patients that had hormone receptor positive disease, the response rate was about 27%. But you see in this waterfall plot that the vast majority of patients had some benefit from this drug. Everybody really had seen CDK4/6 inhibitors, and most patients had a median of 2 prior therapies here. Progression-free survival was 8.3 months. So this has led to Tropion Breast-01. This is a phase 3 trial of Dato-DXd in hormone receptor positive disease. These will be patients that have hormone receptor positive disease, have exhausted their endocrine therapies, have received at least one line of chemotherapy, and then they're randomized to get the antibody drug conjugate, Dato-DXd, or investigator's choice chemotherapy. And you can see there's multiple choices here. This has completed accrual. And so we will wait to see more data here.
Any comments on toxicity of data? What we've heard from the lung people is mucositis.
Yeah, we certainly do see mucositis. It's interesting. Melissa Johnson has been using Dato for lung here, and I've been using Dato for breast. And I seem to be doing a little bit better in terms of breast than lung. And I've talked to Alex Spira, and it's kind of the same story. I don't know why, but it seems like the patients with lung cancer have a little bit tougher time than the patients with breast cancer. And we haven't been able to quite figure that out. Certainly, steroid mouthwash is very important. In my experience, that when you get the mucositis, it is very tough to get rid of. It's much better in preventing it. And so I really have to counsel my patients quite aggressively. You know, they use the mouthwash. They're like, oh, I don't have mouth sores. And they stop it. And then you get in trouble because you can't get rid of it once it happens. And so I really have to tell patients, I need you to use the mouthwash. Even if you're doing well, you've got to keep using the mouthwash, right? But it can be challenging.
All right, let's hear about your cases.
So this is a patient with ER positive disease that's HER2 negative. She was initially diagnosed in 2005, had about a 2-centimeter invasive ductal carcinoma, intermediate grade, highly ER/PR positive, HER2 IHC of 0 and negative sentinel lymph nodes. She had adjuvant radiation and she had tamoxifen, then followed by letrozole for a total duration of about 8 years through 2013. About 4 years later, she relapsed and was found to have lung metastases at that time. She received about 3 years of letrozole and palbociclib at that point. And then in the second line setting, when she progressed, she enrolled under the SERENA-2 trial with camizestrant. We quickly figured out that she did receive camizestrant based on the fact that she had the visual disturbances that can be a little bit characteristics. She had a little bit of grade 1 arthralgias. She had some bone mets as well, but did quite well and actually still remains on camizestrant treatment as part of the clinical trial. So I think this highlights, you know, a very real world scenario of patients that relapsed a little bit further out from their endocrine therapy and, you know, got good benefit in the first line setting from letrozole and palbociclib. So a patient that were very motivated to try to keep on endocrine therapy and not move to chemotherapy too soon.
Do you know what her ESR1 status?
I don't. No, we didn't know that going into it. I think we had checked that once she was enrolled, but wasn't known up front.
So I'm curious when she first reported to you visual disturbance. What did she actually say? How long was it after she started the therapy?
Yeah, it happens pretty quickly. I counsel all of my patients that it may happen because, you know, if somebody's getting waffly vision on the side of their eyes, they think something's wrong if they're not aware that it's going to happen. And so I say, oh, you may notice this. And so when she came back about 2 weeks on therapy, she said, I did notice it, but, you know, it's not very bothersome. Interestingly, some of my patients at kind of the 2 and 3 month point say it goes away. I don't actually think that they don't have it anymore. I think they get used to it and they stop noticing it. But that's just, you know, my gestalt there.
We actually did a CME program with an onco-ophthalmologist. I spent like an hour and a half talking about like you said, mainly
Yeah.
ADCs. All right, let's see your next case here.
So this lady also had ER positive disease that was HER2 negative, diagnosed back in 2003. A larger tumor, about 5.5 centimeters, high grade, ERPR positive, and HER2 at the time was negative, 1+. We would now say low, but that didn't exist back then. She received neoadjuvant chemotherapy, AC to T, had a lumpectomy, had ultimately some residual disease, and so ended up going on to have bilateral mastectomies. She had 2.2 centimeters of residual invasive ductal carcinoma. She had one positive sentinel lymph node with a 3 millimeter deposit and 3 negative nodes, so 1 out of 4 nodes. And she received aromatase inhibitors for 10 years duration, just based on that higher risk phenotype up front. 4 years later, she relapsed with liver metastases. She received 2 years of letrozole and palbociclib and did need a dose reduction of palbociclib due to counts, not due to fatigue, but just neutrophil issue. And then she had new bone lesions as well as a new lung lesion. Based on profiling, she actually had an AKT mutation and ultimately enrolled on the Capitello trial. She did struggle with diarrhea. She had grade 2 diarrhea, really not tolerable for her. We ended up controlling this with Imodium, and now it's kind of grade 0, grade 1. She ended up kind of getting into a regimen where she would take 2 Imodium in the morning at breakfast, 1 at lunch, and that kind of kept everything under good control. She also had a little bit of grade 1 hyperglycemia, but no medications required and no symptoms from that. So I think this is a patient that's probably quite indicative of, capivasertib in general and how it's tolerated.
Just out of curiosity, I'm curious, we talked about some of the data, but in terms of your own personal experience comparing capi to alpelisib, do you see anybody cruising through either one of those incidentally?
I don't think I've had anybody that's cruised through alpelisib, unfortunately.
Yeah.
I don't want to sell capivasertib as an easy drug, right? I mean, it's not single agent endocrine therapy. There's definitely side effects. I find it easier to manage capivasertib because I find that I'm really treating one thing, which tends to be the diarrhea. The problem with the alpelisib is it could be rash, it could be hyperglycemia, it could be diarrhea, nausea. There's just so many things on the plate that people can struggle with that I think I struggle a little bit more in clinic, kind of wrapping my hands around it and, having that patient tolerate it well. So easily for me, the side effect of capivasertib really is the diarrhea. It's not diarrhea. It's not neratinib diarrhea. It's not abemaciclib diarrhea. I mean, it's more mild, but certainly prevalent in a lot of patients.
That's a great comparison to those two drugs because it really puts it in perspective. Certainly, Abema, I think people have gotten used to.
Right.
I
Absolutely.
think. Well, the other issue is dose reduction. I'm hearing more about dose reduction with Abema. What about with Capi?
Yeah, I mean, there are, as part of the protocols, dose reductions were allowed. I presented some data at ASCO around abemaciclib and dose reduction, and it was really surprising to me in the adjuvant Monarch E trial that of the patients that discontinued abemaciclib, that half did so, more than half actually, did so without ever trying a dose reduction. So I think we need to be a little bit more proactive about telling our patients about dose reductions of, hey, if you're struggling, don't just stop it. Call me. There's things we can do to make you tolerate it better. Because I think what happens with these oral drugs is patients go home, they feel horrible, they just stop it, and they're unwilling to try again because we haven't set the expectation that there are dose reductions available, right?
Yeah, and just in talking about Abema, for example, what I hear is that if you do aggressive dose reduction, you usually don't have to discontinue the drug for diarrhea. Is that your experience?
Absolutely. Absolutely. But that's the problem
Interesting.
is that you kind of blow some patients out of the water and they're just unwilling to try again, right? And so I think that's where, talking to them about dose reduction before they start, so they've got that in their mind of this is what would happen if I didn't tolerate. It's not just I'm quitting, right?
Yeah, I wanted to get into that with the webinar because I was actually telling Kevin also. One of the things I took away from that discussion session at ASCO that you were involved with, and we brought in the Natalie data as well, was this whole concept of dose reduction and the fact that maybe it's not being done as much as it ought to be.
Absolutely. So this case kind of wraps up with a patient that ends up being endocrine resistant. And so patient was initially diagnosed in 2017 with de novo disease, had disease in both the nodes and the bone at that time, received about 4 years of letrozole and palbociclib. So certainly, as anticipated, even a little bit better at that point. Went on to receive exemestane and everolimus and progressed pretty quickly at 4 months with new liver mets. Received capecitabine for almost a year and did pretty well on that. Needed a dose reduction for hand-foot syndrome, but certainly longer benefit with capecitabine. And then profiling revealed a PI3 alteration. So we went back to endocrine therapy at that point, tried fulvestrant and alpelisib. Patient had blood sugar issues, really struggled in terms of eating and fatigue, et cetera. Ended up discontinuing and continued fulvestrant, but progressed at the 4-month point. This patient received sacituzumab govitecan, again, for about 4 months. So you really see that the patient is not getting a duration of benefit from these subsequent therapies as well as we would like. And ultimately enrolled on the patritumab deruxtecan trial and remains ongoing now at 5 months. So I think that this case is interesting to bring up something that we haven't talked about today, which is ADC after ADC. And we don't have a lot of answers there, but it's a big clinical question of, what's the activity of an antibody drug conjugate going to be after an antibody drug conjugate? Is it more important that we switch the target? So TROP2, HER2, HER3. Is it going to be important that we use one with a different payload? And I suspect that this isn't going to be a one-size-fits-all answer, but certainly for this patient, doing quite well on ADC, now on for longer than she was on the first antibody drug conjugate.
I'm just recalling a webinar I did with Pasiani, the Dana-Farber lung cancer, where you're talking about patritumab. And there, they use it in people who are progressing on osimertinib. And which leads to my question in terms of what is HER3? I think my understanding is that to me, it sounds a little like pertuzumab. It's more involved with dimerization, but there's no TKI. But I mean, why are we using an EGFR positive lung cancer and in breast cancer in this situation? Is it just the target, or has nothing to do with it, the underlying situation?
So, you're absolutely correct. It's involved in dimerization with HER2, right? I like to look at the antibody drug conjugates as not really targeted agents, in the fact, when we say targeted agents for TKI, we're interfering with HER2 signaling, right? We're trying to block a receptor and the downstream signaling. I don't think that these antibody drug conjugates are targeted in that fashion. They're not blocking HER2 signaling downstream. In fact, I don't really think trastuzumab deruxtecan and HER2 is really interfering as much with that. I like to think of it as more of a honing device. You're getting chemotherapy to the cell that expresses some of this target, whether it's HER2, TROP2, HER3, and then it's acting like chemotherapy. It's not a tyrosine kinase inhibitor. It's not about signaling. So I think the reason that this is also an active drug in lung is because there's HER3 expression on those lung cancer cell surface. And what we're learning about the antibody drug conjugates is it doesn't take high expression like we've traditionally thought of for HER2, where you really have to have high HER2 expression to benefit from a HER2 agent. This is a different class of molecules.